such as the ability to follow directions. There might be issues with sitting balance or standing balance. There may be tonal issues that we're dealing with. We could consider amputations and those type of things. So we want to use small controlled movements when we're doing our transfers, and we need to consider that we may need to do transfers in a series of movements. One of the key things we want to do is we want to first prepare the environment. And so you're going to say that to me during your lab practicals, and we're going to do it during practice today. And that will cue you to make sure you consider the environment. So when we're getting a person ready for transfer, we don't want to have the Hindu with poor balance sitting on the edge of the bed and the wheelchairs across the room. And there's a chair that they've been setting up in earlier in the day in the way. We want to make sure all that's taken care of before we ever get them into a position where they're sitting unsupported on the edge of the bed, or we don't have whatever device or piece of furniture they're going to transfer to ready. There's clutter, there's wet stuff on the floor. So first thing we do is prepare the environment. So we prepare the physical environment. We prepare the client. What does that mean? We let them know what's going to happen so they know what to expect. So we're going to say, we're going to get out of bed and get into the wheelchair, or we're going to get out of the bed and get on the bedside commode so you can use the toilet like you indicated you need to do. So we'll let them know what's going to happen. And we're going to give them specific information about how we're going to go from point A to point B. I'm going to have you, and we'll give them, it could be verbal cues and visual cues and tactile, depends on what they need. So if they're very confused, less is better as far as conversing about it. So based on their needs, we're going to prepare them. We're going to physically prepare them. So we're going to make sure that they're in a position where their feet can touch the floor, that they have footwear. We never, ever transfer clients without footwear. So if you know they don't have shoes, you're going to go to the central supply closet and get a pair of non-skid slipper socks and put on. If they're too swollen, you're going to cut the edges of the slipper socks so they do fit them. So we don't transfer people without footwear. Okay, so bare feet on the floor, no. But ask family to bring some shoes in, slipper socks, whatever the case may be. So we're going to prepare the patient physically. Get the feet on the floor, have footwear, hand placement if we're doing hand placement, whatever the case may be. After we prepare the client, we then execute the transfer. So prepare the environment, prepare the client, execute the transfer. So we're going to do several different types of transfers today. And I need a volunteer. And I'm going to need to have one of those wheelchairs. So someone needs to give up their seat for me, please. Jamie, give up their seat.
I was going to do it.
It's not right in here, Madame.
I had another. Yeah, he was like, oh.
Okay. In some settings, the organization may choose not to use gait belts. That's their prerogative. For me, you'll always don a gait belt. Gait belts are a safer way of having a client engage in functional mobility and transfers. If you are using the back of their pants, that's a bad idea. I can remember one time my finger going through someone's underwear. I had a hold of the pants.
So tight.
I had a gait belt too, and fabric can tear, and so it's not a good idea. What if they have a hospital gown on? There's nothing to grab a hold of, and they start to lose their balance. So it's a good thing to have. I've had students call me and say, "Oh, they don't use them here. What should I do?" I said, "Well, you can ask if you can use yours. Some facilities have issues with infection control, but there are gait belts that have a plastic coating that you can wipe off in between patients, so that you can use antimicrobials. Or in some settings, you actually assign a gait belt assigned to the patient, and they have it until discharge, and it goes home with them. We're going to use a typical type of gait belt, the cloth gait belt. There are gait belts that snap. So you'll see different types used. We're gonna use a typical cloth gate belt. When you apply the gate belt, you apply it through the teeth first. So see the teeth? These can flop around and get confusing. So you put the opposite end of the gate belt through the first D-ring that's next to the teeth. If you don't do it that way, the gate belt will slip. The teeth actually clamp down on the gate belt and hold it in place. So you must put the gate belt on the teeth side first. Right? Then it goes to the other side of the D-ring. When we put the gate belt on, the first thing we're going to do is check our abdomen of our patient. So we're feeling for like peg tubes, like feeding tubes, incisions, drains. We'll ask them, and we also want to check because sometimes people aren't accurate, because we cannot put a gate belt over those. I remember having a young patient who had an organ transplant, and he had so much edema they couldn't stitch him back up. So he actually had mesh and dressing over his internal organs. And so we couldn't put the gate belt on. We usually put it around the waist, and I couldn't. So it can go a little higher. We don't like to put it up high, but it can go above the breast if need be. We have to be careful because we don't want to go under the axilla and cause brachial plexus damage. But we can go above the breast if we have to. If we establish that there are no incisions, tubes, or drains, we can put it at the waist. When we have larger breasted women, excuse me, we want to make sure that we're not putting the gate belt over the breast. So the breast can be lower than typical if you're breasty and if you're older. So we have to make sure we don't get breast tissue because it's uncomfortable. When we put the gate belt on the patient, we make it nice and snug. Maybe 2 fingers can get between ourselves and the gate belt. Keeping in mind that when we go from sit to stand, it's going to loosen. So we may need to tighten.
You're saying, so are we gonna ask them to
So I
adjust
ask them
it?
to lift the breast.
Okay, I was like,
Yeah.
or are you gonna place it up higher
I would
if
ask
need
them
be?
to lift the breast.
Okay.
Yeah.
What about like edema in the abdomen area?
As
Okay,
long as it's not
these-
painful,
okay.
you might have people who have ascites and things like that. No big deals. Gate belts do come in different sizes, so you have to make sure you have a good fit. All right. So I'm going to have my lovely patient. I think I'm going to have her go ahead and go on the mat instead.
Okay.
All right. So the first thing I'm going to do today, we're going to do 3 different types of pivots. We're going to do a squat pivot, stand pivot, and a stand step pivot. The squat pivot is typically done with a patient who can't come into full standing. So they may be fearful or may just not have the strength to get into full standing. So this person is going to come into the squat position. So the first thing I'm going to do before I get my patient's ready, of course, is I'm going to sanitize my hands and introduce myself. Hi, Holly, how are you?
Good, how are you?
I'm good. I'm enjoying my occupational therapy. I hear you want to get on the potty today.
Yes.
Okay, well, that sounds good. We're going to get you up and in the chair. So I'm going to get her in a wheelchair first, and then we're going to go to the bathroom. So first I need to get some things ready, okay?
Okay.
Okay. Now, I need to back up for just a moment and talk to you a little bit about wheelchairs before we get Miss Holly ready. Different chairs are going to look different. Different vendors are going to look different. And the make of the chair. We just have standard chairs with swing away, armrest, and leg rest. So if you know the nuances of just a standard chair, you should be okay managing other chairs. You need to know how to do this because you're going to be taking things on and off. When you are taking off leg rests, there typically is a lever to the side, and push the lever in towards the chair and swing up and take it off. There are chairs that have posts, and you put the post inside of an opening on the frame. So we're going to take these leg rests off before we get Miss Holly started. Some armrests are removable and they come off completely. These are swing away, and we just push the tab and we can swing the armrest away. It doesn't come off all the way, but it swings away. When you want to fold a chair, you grab each side of the seat and pull it up. when it's time to open it back up, you're going to go on each side of the frame and push it into an open position. Okay? So let's look at the DME for the toilet real quick. So we get our lovely lady since she wants to go on the potty. So can you bring that out?
You got it?
So, it's fine.
You got it. It's okay. You got it.
Sorry, lovely PTs, we love you. Sorry about the disaster. So Dr. Von Durk comes out with flashing orange hair.
Yeah.
After that, I was like, oh, she said, you just remember passing in here with Dr. Von Durk with flashing hair. I'm like, yeah, right, look. So some of the quick equipment we're going to be looking at today are the bedside commodes. Thank you, ma'am. This is, we can put Halloween candy in here.
Yeah.
That's not enough room, actually. I need a bigger one.
Yeah. So there are different types of products we're going to use today. We're going to use my standard bedside commode. And so this is to be used at the bedside. Sometimes we will actually use it over the toilet. So if a person needs handles to push up from, maybe they just don't have enough strength in their quads, they need to use their arms, or they need height, maybe they need a little height so they can get up and down from higher surfaces better, we can use this. The regulations for Medicare and Medicaid have changed, and so people are likely going to pay for it out of their pocket. And so this is less expensive than the specialty chair, and we'll look at it in just a minute. You know, you can use this with a bucket if you are having to use it bedside. Little pearl. Put some water in the bottom before you have a person have a BM, or the poo-poo's going to stick and you're going to have to clean it out. Don't leave poo-poos for nursing staff or family members. So a little bit of water goes a long way. When we sometimes males have to sit to urinate because they don't have the ability to stand, and they're not particularly fond of it, and actually have some difficulty because they're accustomed to standing. But the sleeves are nice, particularly if there is a significant difference between the seat height of this and the toilet bowl. So there could be several inches between the two. So if a gentleman tucks his privates down and doesn't tuck them down enough, we can spray through. And so having the sleeve on prevents that. So that's something to think about when we're dealing with the male population. Later for treats. This is a drop arm commode. And so the drop arm commodes are really nice when you have a transfer board. When you're transferring with a transfer board, excuse me, you need to have the barrier removed. Can you pass that? This one, Dolly, thank you. And I'll show you why. So if I am transferring a client from the wheelchair to the commode, and I'm placing the board, look what this does. That does not create a safe environment. See how the board's going to shift a little bit anyways, and see how it's not in a position where it will safely stay. Mm-hmm. So you might see this done. This is not safe. So we need a removable arm or a drop arm to safely be able to place the transfer board. I'll show you. And we'll talk about the specifics of how to set up in just a moment. A difference in the products. So see the difference and how I can lift more safely. Of course, the lid would be up if we're going to actually do some business. This would be closer, of course, some brakes and stuff. But see how this is much safer? When we are using stand pivots, squat pivots, step pivots, and we're transferring our patients to and from surfaces. When possible, we want to eliminate barriers. For example, if I'm doing a, I think just want to get in here real quick.
Yeah.
Just have a seat there. Sorry, I'm all choked up since lunch. So this is, we're not going to do this exact yet. We're just going to kind of give you an example. So let's say that Holly is a max assist for a squat pivot. She can't come into full standing. And I'm just going to let you stand up for me. We're not, this is not how we would do it because we have a seat belt on. And she starts to lose her balance. And the leg, excuse me, right here, she starts to sit on the armrest. So that could be uncomfortable, to say the least, right? And then safe. So I can't, you can have a seat. Okay. So I can't safely get her to a seated position because that's in the way. So you may be in facilities where they don't have drop arms because they are more expensive. The patient may not qualify for one, they can't afford one. Then you do what you have to do. But for our learning purposes, we're going to do it the safest way possible, which is to minimize barriers. So the barrier between her going from point A to point B is the armrest of the chair and the armrest of the toilet, if I'm doing a bedside commode, or the armrest of the chair and the bed. So we're going to minimize those things. So for me, when we do stand, squat, or stand step pivots, we're going to use the drop arm commodes and we're going to remove the arms. We're always going to remove the arms on the wheelchair, on the side that they're transferring to, the one arm. And you're always going to remove the leg rests. Now some therapists and some of you will try removing one leg rest, the side that you're transferring to. However, if the patient starts to have a descent, maybe a rehab aid's willing to help me or another therapist, or I have to move quickly in another direction to prevent the fall, if that leg rest is still on the side that I'm not transferring to, good butt shot. And it's easier to approach this from the side and put them on. Some therapists will leave it like this or even leave it like this. Got a rehab aid running to help me because she's starting to have a descent. They get caught in the leg rest. I try to move, get caught. So you want to remove anything that could potentially be a hazard. Don't put these on the floor. Put them under something or on top of something. Excuse me, but you want them out of the way for safety's sake. Do you want some water? I've got a drink over there. It's going to go away when it's going to go away, unfortunately. Thank you, Bella. Okay. Young lady. So the first thing I'm going to do is going to do a squat pivot. Squat pivots, again, are used for people who cannot come into standing.
And full standing?
So they can't come into full stand. So this person, I want them to feel weight bearing through their legs. I want them to see what it feels like to be vertical. I don't want to use a transfer board. I don't want to use a Hoyer lift because that's not training them how to move. I may do the squat pivot. Now, remember, there can be different levels of assistance for any of these transfers. And there can be different presentations. So, she may be a hemi. She may be in orthopedic surgery. She may have had a cabbage, whatever the case may be. We're going to keep these things in consideration. And that's going to change things. So I'm going to set the environment up. There's no water, there's no carpet, there's no furniture. So when I do the transfer, I'm going to angle my chair 30 to 40 degrees in the direction of transfer. That means that the seat faces the person. So if she is sitting in here, her eyes should be looking at where she's transferring to. So we don't do this for this type of transfer. And we don't do this for this type of transfer. But we turn the chair 30 to 40 degrees. And I usually will start parallel and then I'll turn. And you can see it's like a little piece of pie. Right? We have angles like pie shapes in both directions. I'm going to make sure that the coasters on the wheels are out of the way. I'm going to remove the barrier.